much. My talk will be in biomechanics, so it's also a little bit different from what we have been listening before. And I'm talking about mainly a methodological issue, is on the use of clinical motion analysis, clinical movement analysis to evaluate the effect of, or to evaluate effects of osteoarthritis, especially to try to ascertain the levels of risk associated with moment, abduction moment, or moments in the plantar, in the frontal plane, in gait in osteoarthritic patients. This is the web page of my lab, and so if we do some other types of studies, all related with biomechanics and a lot with musculoskeletal modeling. So if you have any, and let's say that one of the main objectives that we have is to develop subject-specific musculoskeletal modeling. So the aim of the presentation is to describe the integration of biomechanics experimental techniques with modeling, and to try to develop subject-specific musculoskeletal models using mainly image, medical image, or any kind of additional information coming from the patient. To discuss the application of these subject-specific musculoskeletal models to accurately estimate mechanical loading, joint mechanical loading in osteoarthritic patients, especially knee osteoarthritic, and to address these results after one main issue is that the correction of pelvis shape and size and muscle insertion to estimate mechanical loading on the knee. So what is the basis of the presentation is that, first of all, biomechanics gait pattern is usually associated with knee osteoarthritis risk. And clinical gait analysis is currently used to estimate joint loading in subjects with osteoarthritis, and in particularly knee adduction moment of force is considered as a marker for medial compartment OA severity. Commonly, biomechanical clinical gait analysis uses models that are scaled, or let's say that they are based in body segment, that the scale is only based on skin markers outside, skin marker placement. So the scaling is done by the external measurements, and some of the joint centers are estimated based on either cadaveric models or correlation equations. Joint moments of force estimated using clinical gait analysis are used to establish sometimes OA risk factors, and also to evaluate therapeutic intervention programs, or the use of orthotics, the use of insoles in order to change the moment basically in the coronal or frontal plane. But sometimes the people that prescribe, either medical doctors or pediatricians or podiatricians, I mean, are not aware of how do these moments of force are calculated. So let's do a quick overview of that. What is clinical gait analysis? Then we will talk a little bit about how the 3D biomechanics models are developed and how can it be corrected using some information from image analysis, and then to verify the difference on the values on the mechanical loading that is obtained on hip, knee, and hip, knee, and ankle joints. And further than to use just rigid body type of models that allow us to calculate joint moments, we also use this data to obtain or to develop musculoskeletal models. Let's say models that have, besides the rigid bodies, the skeletal part, we'll also have the, in our case, 92 models for the lower limb, lower extremities. When we develop musculoskeletal models, then we are able to estimate muscle tension. We can even divide or study muscle fiber tension and tendon tension. But in this case, we are not going to discuss these issues. But knowing the muscle forces, we can compute the bone-on-bone forces. Because bone-on-bone forces are developed by weight and by ground reaction force, but a lot of substantial part of the bone-on-bone compression is due to the muscle action. That usually is not considered when you use just clinical gait models. So how is clinical gait analysis done? So you have cameras that are placed around the system. They have to be calibrated. Markers are placed on skin in special positions, so you can have an anatomical meaning, and some of them have an anatomical meaning, and some of them are for tracking, just for following the movement. And usually you have a static trial, what is an anatomical, let's say, a definition of an anatomical initial position or neutral position, and also to scale the model. And then you have the dynamic trials. So you have cameras that are placed around the subject in different possible positions. These cameras are usually infrared cameras that are specially developed to be highly accurate. And this is one configuration in our lab, in our case with 14 cameras, high speed and with high resolution. They are calibrated, and with the calibration you also build a coordinate system, so a global coordinate system. You have a volume where you have high levels of precision if you have high performance system. In our case, we have residuals on the markers that are below 0.4 of a millimeter. And then if one marker is tracked by at least 2 cameras, we can follow up in the three-dimensional path of this marker. And if we relate the markers with anatomical structures, we can, and we do that using different kind of skin marker placement situations or possibilities. This is the most traditional one, the LNAs or the modified LNAs is what Viking system uses, and mainly clinical gait analysis performed under using this distribution of markers. So what main happened is that in the static trial, we have markers that will have anatomical relation. Basically, they will allow us to obtain the joint positioning, central, and to determine where the rigid bodies will interact together. Okay, if we do that for a full body, or for in our case we use lower limb, pelvis, and trunk, and then we will have our static trial, and in this trial we have what is the standing position or neutral position of a subject. Then we can have a dynamic trial in a treadmill, for instance, in this case in an instrumented treadmill, or overground in the lab, where you can see that we have force plates that will allow us to measure the ground reaction force and to relate ground reaction force with the position of the anatomical joints. But what happens is that, so we have markers, the markers have to be verified, have to have a high quality of the determination of their position in space. But after that, what we have to, and these markers will have relation with the skeleton. We'll have to have, let's say, meaning in the skeletal. Each marker have to be related to a segment, body segment, and we need at least three non-collinear markers to define the position of a body in the space. So, but each marker is or each segment is defined with their own local reference frame, and this reference frame has to be then related to the reference frame of the segment there is a joint to this one. So in fact, during the movement, what is estimated is the position of a local reference frame for a segment in relation to the global reference frame for the segment that is connected to him, or to any other segment, in fact, because there will be rigid bodies in space in 3D. And I will spare you for some of the mathematics, but the issue is that in this construction, the anatomical reference frame for each segment has anatomical meaning, so can be described in frontal plane or sagittal plane, so flexion, extension, abduction, adduction, internal rotation, external rotation. But they have anatomical meaning, but they are not vectors, so a lot of some of the operations that you usually want to do are not viable. Okay, so first of all, you have we have the best solution for the position of the markers, but we assume that each marker is placed on skin and can have some movement. So in fact, we have a redundancy of markers. We have more than the 3 markers that is needed. And the position of the segment is obtained with the best fit. So it's like an optimized positioning of the segments. But in fact, what they are is rigid bodies in space, and then we associate it with a constraint on a joint. So each joint has to be described with some constraints, like the knee has, for instance, the linear movement of one segment in relation to the other has to be minimum. Okay, so then we build a model, and we have a complete model in our case. And when we have that in a statical position, we scale the model, and then we can follow a normal pattern. In this case, we have for the right leg during gait, normalized against the gait cycle, and we have the joint moments of force in the sagittal, frontal, on the sagittal, on the frontal, and on the horizontal or rotational plane. And what is the external moment of force? Basically, if we consider the effect of the ground reaction force, in one moment, an instant in time, a force is applied by the ground as a reaction to the body, and we'll create a torque or a moment of force, a rotational force around a joint. And if we do a simplification, it's an external moment of force, is a multiplication by the ground reaction vector by the distance to the joint in a perpendicular way. So in this case, if we have a ground reaction force of 800 newtons, and the distance, for instance, to the center of the ankle joint will be 8 millimeters, then we will have a 64 Newton meters moment of force in the sagittal plane. Okay, so basically it's this. If we see that and we have a minimal movement, means that internal force has to act to balance the external moment. And in this case, if we have standing position, then we will have an ankle plantar flexor moment that has the same amount. If we have acceleration, then we have to consider inertial factors on the body segments, and we can add that and estimate what needs to be the internal moment of force produced by muscles, and also the passive forces on the joints. Okay? But first of all, we need to know how the body segments are built on the model, and they are built basically defining the joint centers of, in this case, the hip joint center, the knee joint center, the ankle joint center, and so on. What happens when we have someone that belongs to a cohort of patients with knee osteoarthritis that are involved in any kind of treatment or therapeutic intervention? In our case, was an exercise intervention of 6 months aquatic exercise as prescribed by in this case by the American Society, but by American Foundation of Aquatic Research, or osteoarthritic treatment type of aquatic exercise. And we have the external markers. The external markers are these 4 markers. And with these 4 markers, we use the same algorithm that Viken, for instance, used to estimate the position of the hip. But it's easy to verify that these markers are very far apart from the actual positions on the pelvis that we want to locate, and that we will be able to locate, for instance, if we have CP kid, cerebral palsy kid, very lean, or if we have an athlete, but it's completely different when we have an obese person. And what we want to estimate is these 2 joint centers, basically. What we did in this case is to obtain the data normally, like with the skin markers only, and then recalibrate or construct the pelvis based on the frontal plane densitometry image. So the correction is only performed in the frontal plane. For the anterior posterior plane, what we did is to maintain the same factor that is used on the paper that estimates the position of the joint center based on these 4 markers. So right and left anterior posterior spine, and back posterior spines, left and right. But we also estimated directly the position of the joint centers. So we built 2 models. They are clear here. We have the more yellowish big hip that is obtained using tracking markers. And one of the main problems is that when you go to a gait lab, or a surgeon or a rheumatologist ask some tests done on the gait lab, they don't know how the system works. They don't know what kind of calculation is done. So they don't notice this absurd size of the pelvis, okay, that happens when you use the basic system. So what we did is we built 2 models, and we compared what happens to the correct model against the non-corrected model. And it's clear that for all the either joint angles and also moments of force, but especially moments of force, both on the sagittal plane, even if on the sagittal plane there is not that huge deviation. So we have bigger deviation on the hip and smaller on knee and ankle. But on the frontal plane, this is clearly an issue. And what we tried to basically estimate, if we go for the for the knee and moment on the left, on the right leg, is to know or to calculate the distance between the ground reaction as a crude image, the distance between the joint center and the ground reaction force. And if you have a pelvis that is really incorrect, then the data will be also highly incorrect. When it's obvious for almost everybody that for knee OA, the level of loading on the compartment on the knee will be a major factor. And we would like to know also what will be the effect of if we estimate different compression forces on the knee. So for that we build a musculoskeletal model. So basically we use the data coming from the gait lab to build a musculoskeletal model. In our case, is built under OpenSim from the University of Stanford. It's an open source software for developing musculoskeletal models. And what a musculoskeletal model does is a little bit complicated, so I don't go into detail. But what accounts for the observed movement, about musculoskeletal geometry. So we incorporate muscles in the correct points of insertion, and with a distribution of the main mechanical properties that is associated with each muscle, like pronation angle, cross-sectional area, characteristics of activation, types of fibers and length and proportion of fiber and tendon, and so on. We have to estimate or to use some kind of activation system that usually is based on a sound physiological rationale, like minimizing tension or minimizing expenditure of energy, to have the best solution for the muscles to develop the force that is necessary to apply one movement that we observed. So then we can have a musculoskeletal model, and the way that you should do it, this graphical representation will be the red the muscle is, the higher the level of activation of force that is performed. If it's blue, means that it's not activated. So we can observe the same type of movement, and you can see that for each muscle, in this case is for one stride, we can estimate what the muscles are doing. And when we do that, then we can compare correct versus non-correct muscle activation. And again, we can see that, for instance, for hip muscles, usually the correct the activation estimated with the correct subject-specific data will be lower. So not non-correcting will tend to overestimate the force that the muscle needs to produce. But this can be very different for rectus femoris, for instance. So for the knee muscles, what happens is that usually that difference is even higher than for the hip muscles. And as a consequence, when we add all the tension that the muscle produces, you know that just a part of the tension of the muscle will perform rotation. The majority of the muscle action in gait will do compression of the two bones, so what is a bone-on-bone force. And also is clearly seen when we compare corrected with non-corrected, and we calculated hip on femur, knee on tibia, and ankle on talus. And it's easy to see that on the hip we have some difference. And again, this is negative because it's joint reaction. Notice that the value can be very high, several times body weight, which is normal because we are the body weight, ground reaction force, and tension that the muscles do for contraction. And the majority of the muscle tension will be acting axially on the bones, or compressing one muscle against the other. So it's also easy to see, not with this, well, probably I was trying to, the yellowish, mean the hip, the knee, what is the most important. It's clearly less amounts of compression on the corrected moment than the other one. Okay, so as our results show that in osteoarthritic patients we have a high level of soft tissue artifact, and very difficult to obtain the real position of bones and, as a consequence, joints. We should use image analysis data, medical image data, or to be extremely careful on the determination of the position, the real position of the bony landmarks, and we couldn't trust on just markers placed on skin, especially on the coronal plane, on frontal plane. And these inaccuracies resulting from non-specific musculoskeletal models fail to obtain correct muscle activation, and as a consequence, an inaccurate estimation on bone-on-bone compression forces. So thank you very much for your attention.
I would like to thank for your good presentation, very interesting, and it's good to see that you took in account the soft tissue, because with biomechanics specialists we see the body without muscles, and we know that the reaction of the muscles can change the expected results of a joint movement. So that's good to see that. Did you see in your patient with osteoarthritis having a weakness of muscles before the investigation, and then after the treatment, when those muscles who were weak better, working better?
Well, as I told you, the work done in osteoarthritic patients, yes, there's a group of 60 osteoarthritic patients that were involved in an exercise program for 6 months, and the improvement or the changes on their body was evaluated in different conditions, let's say, in a multi-level way. So anti-inflammatory or inflammatory indications and strength and all that. So they almost all improved substantially. But when all of them were tested, so we had 60 pre and post biomechanical analysis, including the DEXA analysis also. So they do improve, okay? But what we found that when we started, one of the reasons that we did the biomechanics study as normal, as it's done normally in this case of studies, to verify if they have a reduced CAM, so knee adduction moment. And when we started to do that, the first thing that we did is to study for variability, and the variability is super high. And if you have a lot of fat tissue, the replacement of the markers will be another question. So we really need to use additional information.
Yeah, one more quick question.
Dr. Veloso, thank you for a great presentation. I just had a quick question regarding your gait analysis and muscle function. Can you concentrate on the more subset analysis? For example, if you have patients with patellofemoral problems or anterior knee pain, could you see and assess firing of the VMO and how effective that is?
Yeah, that's possible. That's one of the, let's say, these models. If you go to the OpenSim repository, it's developed by the neuromuscular biomechanics laboratory of Stanford University, and you will see that they have a lot of studies done with different types of
Pathology and problems.
Pathological problems. But in our case, we can study or to estimate the level of tension on the patella, for instance, if you simulate the patella. But the more detailed information you want to have, the higher amount of information we need to receive from the patient. So we, for instance, for athletes, we use MRI to estimate the muscle properties, because athletes will have completely different muscle properties than the normal population, for instance. And also, like cross-sectional areas where it could be like 3 times fiber lengths will be completely different also, higher, longer fiber lengths. But yes, so if you have an athlete with patellofemoral pain, we can address all these changes and to develop a musculoskeletal model for these athletes.